Welcome to AETCM, the emergency medicine channel. An elderly patient was brought to ER with complaints of melena since last 2 days. On initial 10-second assessment, patient's airway was patent, patient was speaking in full sentences, breathing-wise respiratory rate of 16 per minute with saturation of 98% room air, circulation BP was 70-50, pulse rate of 90 per minute, and peripheries were cold. At this point, we started the patients on IV fluids.
So, first you need to tell that two large bore IV
cannulas were put, and we started him on IV fluids. 1 pint NS bolus was given.
No, this patient is an elderly patient. So, before starting IV fluids, what you need to do?
You have to assess the
the fluid status.
Of the
what
patient.
was the fluid status of this patient?
IVC was mid-dilated, like collapsible, but not fully collapsible. It was. Respiratory variation was there.
Okay. What about the echo?
Echo, ma'am, it was moderate LV.
Okay.
Then, ma'am, coming to disability.
So, only 500 ml was bolus?
Only 500 ml bolus.
Okay. Then what was the reassessment BP?
80/50.
80/50, okay. So,
when coming to disability, patient was having full GCS, but
no, without stabilizing the circulation, you can't go to the disability. So, repeat BP was 80/50.
And we put him on 100 ml per hour for the time being, and we went ahead with our assessment.
Okay. So, what will be the next step if the patient so maximum 250 ml bolus only we might be able to do because moderate LV dysfunction IVC is not collapsible. So, if the patient's BP is not recording, then we'll have to start any vasopressor supports. Okay.
We started on 100 ml, then we again checked BP was still 80/50. We started NORAD 4 ml per hour.
Okay.
Then, ma'am, disability wise, patient's GCS was full, but his response is a bit slow. Like if he asked to do something, he'll respond a bit slowly. Pupils bilaterally equally reactive. Exposure wise, he was afebrile and GRBS was 150 milligram per deciliter.
Why was his response low?
Because BP was 70.
Maybe because of hypotension, reduced perfusion to the brain. Okay.
Coming to adjuncts to primary survey,
GRBS was normal.
Was 150.
Okay.
Adjuncts to primary survey, we took a VBG and a CBC-CRP point of care and an ECG. ECG was normal sinus rhythm. There were no acute STT changes.
This patient had hypotension without tachycardia.
Without tachycardia.
Why?
Patient is already on beta blockers now. He's
okay.
Patient. Then, ma'am, coming to adjuncts, CBC-CRP point of care showed a total count of 9,000.
What was the ABG finding?
VBG wise, ma'am, patient no acid-base abnormality, no electrolyte abnormality, but lactate was 3.2.
Okay.
Then, ma'am, total counts was 9,000 and hemoglobin of 4.8 with platelets of 169 and CRP of 1.
Okay.
So, at this point, we sent arrangement for PRBC, 4-point PRBC. Then,
so, this patient came with history of melena. On examination, patient was having hypotension. So, it can be cardiogenic because patient is having LV dysfunction, or it can be because of hypovolemia. So, with this background of anemia, we can tell that this might be because of the hypovolemia.
Okay. So, I'm coming to sample history. Patient came to ER with complaints of dizziness and 2 days of melena. He was also having slight fever. On arrival to ER, patient was conscious, obeying commands, but replying slowly. He is not allergic to any known substance. Medication was patient was on warfarin, digoxin, and rosuvastatin, and carvedilol. Then coming to past medical history.
Any antiplatelets?
He is on clopidogrel.
So, clopidogrel is there, warfarin is there.
Warfarin is also there. Then coming to past medical history, patient is a known case of rheumatic heart disease, mitral valve collapse with moderate MR, moderate AR, status post dual valve replacement, CAD, coronary artery disease, dyslipidemia, and has previous history of anemia due to GI bleed. Last meal consumed was 1 hour back. Events, patient had complaints of fever since 2 days and melena since 2 days, around 2 to 3 episodes. There was no history of any vomiting, any hematomesis. Patient was taking a warfarin tablet and his last INR, which was checked 7 days back, was 2.03. Patient had also gives history of consumption of paracetamol tablets, only 2 tablets over the course of 2 days. No history of any drug overdose or any consumption of any other new drug, and or any alcohol consumption, pain abdomen.
Any new foods did he take?
No, ma'am. No. Only 2 paracetamol tablets he had taken. On systemic examination, all systems were under within normal limits. Then we had done one point of care INR for the patient. It came out to be 8. We gave injection vitamin K to the patient, and also in the meantime arranged for FFP. On reassessment, our BP had come to be 80/50, so we had started on IV fluids 100 ml, and well as we started NORAD, and we have asked for PRBC transfusion also. So also cardiology and gastromedicine both consults were given. Patient was kept NPU. Then when PRBC came, we stopped the fluids, started the patient on PRBC transfusion, and also 1 pint FFP was transfused for the patient. Following which, patient's BP started picking up and we could start tapering the NORAD. After 1 pint PRBC, repeat hemoglobin came to be 6. So we have transfused another PRBC to the patient, and that lab INR value had come initially to be no clot detected, which after 1 pint FFP came out to be 3.5, and then one other pint was transfused. And then patient was admitted under cardiology.
So, what is the ideal dose of FFP which you give?
4 FFPs.
No, what is the ml per kg FFP required?
20 ml per kg.
Yeah, if 15 to 20 ml per kg is the dose of FFP required for a patient. So, this patient only 1 FFP was given?
Only 1 was given at that moment, but it got corrected. From no clot 2, it came to 3.
Okay, any OGD or anything was done?
Ma'am, later, after admission, patient was undertaken for OGD as well as colonoscopy, ma'am. OGD was normal. Colonoscopy revealed internal hemorrhoids, but there was no fresh or altered blood noted up till terminal ileum. But hemorrhoid, they have done hemorrhoidal sclerotherapy at 11 and 3 o'clock position, because patient was having UGA bleed.
Okay, so this patient came with GA bleed with hypertension because of hypovolemia, and HB was low because of the bleed, and also since the patient is on warfarin, we don't know what triggered for the variation in the INR value, but with maybe some medicines or some food items, there was some problem. Because of that, the patient's INR went high. Okay, so warfarin, where does it act?
Warfarin is a vitamin K antagonist, so it will inhibit vitamin K epoxide reductase, so that enzyme will not be reduced. So if that enzyme is not being able to reduce, then it needs to act as a cofactor for gamma carboxylation of vitamin K dependent coagulation factors that are 2, 7, 9 and 10. Since it has inhibited the enzyme vitamin K epoxide reductase, this gamma carboxylation cannot happen. As a result of which, vitamin K dependent factors, that is 2, 7, 9 and 10, they cannot act. They cannot bind with calcium and phospholipid membrane, and that action is stopped.
Okay, so so if there is any bleeding, what will happen? There is a primary coagulation and secondary clotting process. So primary clotting process will be controlled by the platelets and then from the endothelial layer, platelets, everything will come and form the primary clot. Then the secondary clot will be formed. So then comes our coagulation pathway. So what all are the coagulation pathway agents and factors?
Two coagulation pathways. Basically, we have the intrinsic pathway and the extrinsic pathway, and they both combine to form the common pathway. So, intrinsic pathway is activated by factor 12. It gets any injury to any tissue, factor 12 gets activated to 12A, which in turn activates factor 11 to factor 11A. Then factor 11A along with calcium will activate factor 9, which will get activated to factor 9A. Then 9A, calcium and factor 8, which is activated by thrombin. All these three will combine to form factor 10A, which comes under common pathway. And from extrinsic pathway, we have tissue factor 3 that will activate into 3A, and then factor 10, 3A will again act on factor 10 to activate factor 10.
Not 3A7. Extrinsic pathway by factor 7.
Factor 7 and factor 3. And from intrinsic pathway, factor 8, factor 9. They will activate factor 10. Then factor 10 will be activated form of factor 10 will convert 2 to 2A. That is, we get the thrombin. And that
Prothrombin to thrombin.
Prothrombin to thrombin, and that will activate factor 1 to factor 1A. That becomes fibrin.
Fibrinogen to fibrin.
And then with calcium, it becomes the sable fibrin cloth.
Okay. So this patient, you told that APTT was 8 and no, INR was 8.
In point of
What was the APTT value?
APTT value of the patient was times 53, ma'am.
53. Okay. So you didn't tell about the other parameters. You told about the HB. What was the platelet value?
169.
169. So platelet is normal. So usually if a patient comes with bleeding and if you are suspecting anything with the clotting or the bleeding, this thing, first we'll have to check for the hemoglobin, of course, to look for the loss. Then platelet. So this patient platelet is in the normal value. Then we'll have to look the APTT. APTT, this patient's
53.
53. What is the normal expected?
30.5.
Between 25 to 30. So this patient's value is slightly high. And INR is also prolonged. What is a normal INR?
1, less than 1.
0.8 to 1.2. That is a normal INR. That is also, so main problem here is the INR. Okay. So if INR is high, what might be the problem? Whether it will be the extrinsic pathway or intrinsic pathway? INR.
Common pathway?
No. You have told the pathway, no? Where does the, what will influence the extrinsic path, the APTT more? APTT is intrinsic pathway. APTT, so APTT is mainly in charge of the factor 8, 9, 11 and 12 are more for the intrinsic pathway. So anything abnormal in that will affect the APTT. So if a patient is having alteration in APTT, that means that there might be some problem with the intrinsic pathway or the common pathway, because APTT not only depicts the problem with the intrinsic pathway, but if anything comes wrong in the intrinsic pathway, the common pathway also will get affected. So either there will be a problem with the intrinsic pathway or common pathway. Whether INR will mostly extrinsic pathway, because INR mostly will be altered if the patient is taking some vitamin K dependent clotting factors. So factor 7 is one of the vitamin K dependent clotting factors. So this patient was on warfarin, which is inhibiting the vitamin K dependent clotting factors. Patient was taking factor 7. So factor 7 is there. So what are the vitamin K dependent clotting factors?
2, 7, 9, 10.
2, 7, 9, 10. So the factor 7 is coming as in the extrinsic pathway. Along with that, it is going to the 10. Next is the 10. So 7 and 10 are affected. So any abnormality if you are seeing in INR, then that means there is some problem with the extrinsic or the common pathway. Common pathway comes in both. So APTT abnormality means there intrinsic and common. INR abnormality means extrinsic and common pathway. Okay. Then so that is the thing. So this patient, the main problem is the extrinsic pathway which you are suspecting. Okay. So this patient is on a vitamin K antagonist coming to ER with an some INR value. So what will be the management? So suppose this patient is not bleeding, only there is variation in the INR which was incidentally found out. So how will you manage?
We can divide that. Basically, if INR level is less than 4.5, 4.5 to 10 or more than 10, and whether bleeding is there or not. If there is no bleeding and INR is more than 10, then we have to stop warfarin and patient can be started on oral vitamin K supplements. If there is no bleeding and INR is between 4.5 to 10, then we'll hold warfarin. Vitamin K can be given or can or cannot be given depending on if risk factors are there. If patient is taking cumarol or patient is a child, then no need to give. But if otherwise patient is having heart failure or such diseases, then we can give in INR 4.5 to 10 without bleeding. Then if INR is less than 4.5 without bleeding, we just should stop the next dose of warfarin. and then we should check it again, or the maintenance dose can be as a whole reduced.
Okay.
And if there is, ma'am, a serious life-threatening bleed, any IC bleed, that irrespective of the INR, we have to give vitamin K, hold the warfarin, and if available, we can give 4-factor PCC or FFP.
Okay. So, if the patient is not bleeding, INR is less than 4.5, just stop warfarin. Between 4.5 to 10, stop warfarin, give oral vitamin K. More than 10, we can give IV vitamin K after stopping warfarin. If the patient is having life-threatening bleeding, we will have to stop warfarin first. Then we will have to give vitamin K and the reversal agent. So, what all are the reversal agents? FFP, you told.
FFP, PCC, then we have vitamin K, all three.
Vitamin K. Okay. So, what is 4-factor PCC?
4-factor PCC will contain only the factors. It will contain 2, 7, 9, 10 in inactivated form. Then we also have 3-factor PCC, which will not contain the 7th factor, but 2, 9, 10 will be there. Factor 7 can be given like additionally if needed.
So, how is 4-factor PCC derived? So, basically, if we are collecting blood from a patient, so blood after centrifugation will be the packed PRBC. The packed PRBC will be in the bottom level. Then there will be a buffy coat. That buffy coat will contain the platelets and rest of the things, and the top layer will be plasma. So, if that plasma is frozen, we will call as the fresh frozen plasma. From that plasma, we can derive the cryoprecipitate and the cryo-free plasma. So, what all things does cryo contain? Cryo will, not all factors. Cryo will contain factor 1, factor 13 and factor 8 fibronectin and all. 1, 13, fibronectin, 8 will be there in cryoprecipitate. So, this patient, then comes the next factors. So, plasma contains all the factors. So, cryo will contain these factors. So, rest of the factors, especially the 2, 7, 9, 10, that is the vitamin K factors will be there in the cryo-free compartment of the plasma, which is dried and kept. That is 4-factor PCC. It usually is dried and kept. It's a dried powder which we will have to reconstitute and give to the patient. So, it will contain 2, 7, 9 and 10. And why this 3-factor PCC is used is because this factor 7 is having very less half-life. So, half-life is very less. So, sometimes we might have to use 3-factor PCC. Okay. So, what is the dose of FFP we have told? What was the dose? 10 to 15 ml per kg. So, if you have only FFP, we can give FFP. So, how will you start FFP to a patient? What was given to this patient? FFP, right? So, how will you start FFP?
Before giving, FFP has to be thawed for some time.
No, FFP is frozen plasma. Not thawing and not. How will you start? What is the rate?
Within 20
thing is, this patient is having moderate LV dysfunction. So, if you are suspecting anything that can cause a fluid overload, we will not be giving that fast. So, in a healthy individual, you can give 2 to 3 ml per kg per hour. Whereas, in a patient who is having a risk of fluid overload, you can give only 1 ml per kg per hour. That is how you give FFP to a patient. Okay. So, this patient FFP was given. If you what is the advantage of 4-factor PCC or FFP?
Fluid overload conditions and anaphylactic reactions can be prevented.
Now, one thing is that for FFP we need ABO cross matching, and if at all it is not available, what is the donor, universal donor of FFP? O negative is for PRBC. FFP, what is which is the AB? Patients who are AB, mostly AB positive individuals are the universal FFP donors. Okay, so we need ABO cross matching. That is one disadvantage. And another thing is that we are planning to give 15 to 20 ml per kg. So it will come around how much? 1 liter you'll have to give. So that also can cause fluid overload. So that time the role of 4-factor PCC will be coming. So what is the dose of 4-factor PCC?
You can give it 1500 to 2000 units IV
ml
over
per
10
kg?
minutes. ml per kg.
You can give like usually it is coming as 25 units per kg. 25 units per kg. So usually 25 units per kg means around 100 ml of after diluting 4-factor PCC we will be getting 2500 international units. So this patient requires only around 2500 units. So only 100 ml needs to be given. So that means that we can prevent fluid overload. But only thing is that it is very costly. As compared to FFP, it is costly. Okay. So this patient FFP was given. Okay.
After that, vitamin K was also given for 3 days. And then slowly patient's INR started improving. It came back to 1.7.
What is the other risk which you need to anticipate during while you are giving FFP? What are the complications which you will expect?
Patient anaphylaxis.
Another thing I forgot to tell is that 4-factor PCC, if you are giving to a patient, cost factors are there. Advantage is that less only you will have to give, but it is highly thrombotic. So if it is highly thrombotic, what will happen?
It will again cause
this patient is having what underlying condition?
rheumatic heart disease.
Rheumatic heart disease. So if you are giving a highly prothrombotic agent, what will happen? What will happen to the valve?
It will get stuck.
Stuck valve. There is a risk of stuck valve. So that should be suspected. That is one complication which might happen to the heart. Then if that is usually with 4-factor PCC, but it might come with FFP also if you are overcorrecting with FFP. And other complications while you are transfusing a patient, either with blood, this patient is receiving blood and also FFP. What are the other complications?
Anaphylaxis.
Anaphylaxis. Other complications related to transfusion. Fluid overload, which needs to be pre-treated and corrected with diuretics. Okay, then while giving PRBC, patient can have hemolytic reactions. Okay, then next of the trally and rest of the things should be suspected. Especially in this patient, most expected complication is fluid overload and stuck valve. Okay, so that should be considered. So if at all the patient is developing stuck valve, what will be the symptoms? Stuck valve, that means mitral stenosis has worsened. What will be the symptoms? What will happen? The valve is stuck. So what will happen?
No flow. Chest pain, breathing difficulty.
There will not be any flow from the left atrium to left ventricle. So what will happen? Pulmonary edema. So fluid overload also will fluid overload and stuck valve will have same symptoms. Patient will be having the same pulmonary edema symptoms. So that should be closely monitored for this patient. Okay. Then what happened to this patient after?
This patient's INR got corrected. He was restarted on warfarin, and then advised to take weekly monitorings, and then like discharged with a hemoglobin of 9.5 at the time of discharge.
Okay. What all are the other coagulation agent which you know?
Other coagulation agents are nowadays we have direct oral anticoagulation agents. So there are one.
Before that, we'll discuss about heparin. Heparin, where does it act? If the patient is getting some heparin dialysis or is on heparin, what all things you need to monitor?
If heparin is there, we have to look for the APTT.
It will affect mostly the intrinsic factors. So APTT should be monitored and
kidney RF.
Usually heparin will be given in renal failure patients. So it is safe for renal failure. So no need to monitor RFT. Then platelets. You need to look for heparin-induced thrombocytopenia. Especially it will manifest after 48 hours.
can
Okay,
also
so
cause
if at all patient is having prolonged APTT or because of heparin, how will you reverse it?
protamine can be given.
Protamine?
Sulfate.
What is the dose?
1 mg protamine sulfate will
Neutralize?
reverse 100 units of heparin.
Okay.
So protamine sulfate can be
Okay.
given.
Then other oral
Then low molecular heparin, enoxaparin can be used. Enoxaparin also can be reversed with protamine 1 mg. Then other oral anticoagulants are direct thrombin inhibitors and direct factor 10A inhibitors. And direct thrombin inhibitors are parenteral as well as oral. Parenteral are bivalirudin and argatroban, and oral is dabigatran. Then direct factor 10A inhibitor is rivaroxaban, apixaban, enoxaban.
How will you monitor? So, if the patient is receiving newer anticoagulation agent, how will you monitor the patient's efficacy?
Usually newer anticoagulants, they don't need monitoring, but we can use TTR to see if any reversible, like if we have given any reversible agent, whether the reversal was effective or not. For that we can see TTR, but usually they don't require monitoring.
And if the patient is receiving 10A and all, we'll have to directly go and check for the 10A value. Otherwise, there won't be much change in the PTN or APTT until and unless there many clotting factors and everything is affected. Severe bleeding and only some variations will be seen. Okay. So, how will you reverse it if the patient is having issues secondary to dabigatran?
And we can give patient idarisuzumab, which is a reversal agent for specific to dabigatran.
Dose?
Dose of idarisuzumab
50 mg can be given.
50 mg.
Then what is the reversal agent for 10A inhibitors?
And dexamethasone alpha.
Okay, dose? So, if the patient is taking apixaban, the dose is 400 mg. 400 mg IV you will have to give, at Dixon alpha you will have to give 400 mg stat followed by, stat means we will have to give 30 mg every minute. So, stat followed by 400 microgram per minute infusion.
400 microgram per minute.
That is if the patient is taking apixaban. The patient is taking rivaroxaban, you will have to give 800 mg stat followed by 8 microgram per minute infusion. So initially what I told us for apixaban, 400 mg stat followed by 4 mg per minute. Whereas if patient is taking rivaroxaban, 800 mg stat followed by 8 microgram per minute infusion. Okay. Then what are the other agents which can cause bleeding but cannot be reversed? Not clotting agents. So these things like warfarin we will discuss, then we have discussed about heparin, newer anticoagulation, everything will have a reversal agent. What is the agent which doesn't contain any reversal agent? Which you usually see in all the patients in ER. That is antiplatelets like aspirin and cloplet and all doesn't have any reversal agent. So in that condition we will have to treat, we can withhold for some days, but there is no reversal agent for that. Okay. Anything else?
Warfarin usually has a lot of drug interactions. So if patient is taking any new drug, he should be aware if that can increase the INR of the patient. Most commonly, drug interactions are seen with NSAIDs. It can be seen with aspirin, paracetamol. Paracetamol only if patient takes 2 to 3 grams daily for 2 to 3 days. Other than that, antibiotics like fluoroquinolones, macrolides, metronidazole, penicillins, fluconazole, miconazole, they can also increase the INR of the patient if taken along with patients who are taking warfarin.
Okay.